Let's start here. Good evening, everyone. Dr. Saurabh Rohtagi, Professor Sanjay Gandhi, Dr. Vinita Sharan, and delegates who have joined all from different parts of the world. Welcome to this radiology session on imaging in myelopathies. It is brought by collaboration of GAPIO and with Global Association of Radiological Technologists of Indian origin. On behalf of GAPIO, we extend warm welcome to each one of you. I would like to extend our heartfelt thanks to the organizing team. Myelopathies are a diverse group of disorders that affect spinal cord. They can be caused by a variety of factors, including trauma, infection, inflammation, autoimmune diseases, and tumors. Over the course of session, we'll have privilege of hearing from our distinguished speaker, Dr. Saurabh Rohtagi, and expert colleagues who will share their cutting-edge research, case studies, and insight, and the latest advances in imaging technology that are being used to improve diagnosis and management of myelopathies. Our moderator tonight is Dr. Vinita Sharan, and it will be my privilege to introduce Dr. Vinita. Dr. Vinita is Senior Radiology Consultant at Deep Take Medical Services. She's also Adjunct Faculty of Public Health Foundation of India. Dr. Vinita is former Associate Professor, San Beda College of Medicine, Philippines. She's advisor of radiology CMEs of GAPIO and is very instrumental in organizing the virtual radiology sessions for GAPIO. And this is her 6th session under the mentorship. Thank you, everyone, and welcome, everyone.
Yeah, thank you, Dr. Anju, for the introduction. And greetings to everyone, greetings of the day, wherever you are, whichever part of the world you are in. And for those who had joined us last time would already be knowing Dr. Anju Agarwal. But those who have joined in today, I would like to give a small introduction on her. She is a family physician in Australia with more than 30 years of experience. And Dr. Anju has been awarded with the most prestigious National GP of the Year Australia Award by the Royal Australian College of General Practitioners for her 30 years of service to the community. She is also a council member of the Australian Medical Association, and she is an executive committee member for GAPIO. So thank you, Dr. Anju, for giving us the introductory remark today. And moving ahead, imaging in myelopathies, this is our talk for today. And as Dr. Anju mentioned, it is a disease of the spinal cord, and it has many etiologies. Most of the time, the diagnosis is done on clinical basis, but we use imaging to confirm the disease, also to get the full extent of the disease. And as far as I could understand, there is a paucity of awareness amongst the general population as well as the primary care physicians on myelopathies. And we also have lack of infrastructure and diagnostic facilities for early diagnosis. And since the spinal cord cannot repair itself, or it has a minimal reparative power, it would be, I think, better prognosis will be obtained if we have early diagnosis and intervention. So to guide us today and enlighten us on the diagnostic imaging part of myelopathies, we have Dr. Saurabh Rohtagi. But before that, I would like to introduce our chairperson for the evening, Professor Sanjay Gandhi. So Professor Sanjay Gandhi, he is the Research and Innovation Lead for Core Clinical Service at North Bristol NHS Trust, and he is the lead for radiology and diagnostic imaging at University of Bristol. Dr. Gandhi has won several awards for his contribution to healthcare and innovation, and also higher education in 35 years of his career. The Times TV network honored him as Global Academic Icon, and the British Medical Association honored him as highly commended editor. So Professor Gandhi, he has obtained three postgraduate radiology degrees from UK and abroad, and he has also done a body imaging fellowship from USA. And he has several publications in the international journals. And he has also been instrumental in developing the UK's national imaging guidelines. And he has authored many of the award-winning medical textbook and also developed iPhone teaching app. So I welcome Professor Gandhi to introduce our speaker today. And I just will take one more minute for everyone who has joined in. Thank you for joining us. And if you have any questions, please place it in the chat box. Professor Gandhi.
Thank you, Dr. Vinita, for kind introduction, and thank you, Gapio team, for your invitation to chair this exciting session. As Dr. Anju and Dr. Vinita has mentioned, the importance of myelopathy. When I started medicine about 30 years ago, modern imaging was in infancy. We had plain X-ray, and at the most we had myelogram, which was invasive. And we are today quite fortunate to have world-leading expert Dr. Saurabh Rothgi to talk to us about imaging in myelopathy, because my understanding is, as previous speakers have mentioned, it helps in confirming the diagnosis, determining the causes, and monitoring the progress. But I look forward to hearing from Dr. Saurabh Rothgi. He is a fellowship trained neuroradiologist working at Mass General Hospital and instructor of radiology at Harvard Medical School. He completed his residency at Government Medical College Nagpur and several fellowships, including Medical College of Wisconsin, Milwaukee, and Brigham and Women's Hospital. Prior to joining MGH, Saurabh served as assistant professor of radiology at Emory University and University of Massachusetts Medical School, where he also served as director of community neuroradiology. Saurabh specializes in adult as well as pediatric neuroradiology, and his specialist interest areas include stroke imaging, brain tumor, and neurodegenerative disease. He is actively involved in teaching of medical students, residents, and fellows, and has several publications under his name. So I look forward to hearing from Saurabh.
So it's good morning or good afternoon or good evening, wherever you are in whichever part of the globe you're all. Thank you, organizers, for giving me this wonderful opportunity and honor. And thank you, Dr. Saran, for this invitation. And thank you, Dr. Gandhi, for the kind words and introduction from Dr. Agarwal and the rest of the team. So I can get started. I'm going to share my screen. So my topic today is going to be on imaging approach to myelopathies, and as people who had introduced me had said, that this is an important topic, and it's often not a lot has been described in literature about this. I have no relevant disclosures for this talk. So the outline of the talk is I'm going to talk about the terminology and clinical presentations of myelopathy, review spinal cord anatomy and various compartments in the spine, imaging protocols for MRI, and discuss the various causes of myelopathy and review less common etiologies of myelopathy. So first of all, the most important thing for us is to minimize this, is to identify what the what do we mean by the term myelopathy? So the term myelopathy refers to any process affecting the spinal cord, either within the cord itself or conditions that secondarily affect the cord, such as cord compression. Myelopathy is considered acute when the symptoms progress to within 21 days of onset. If it exhibits a more progressive time course, it is subacute when it's within weeks or months, or chronic when it's months to years. An important distinction between myelopathy and myelitis is that both terms are commonly used interchangeably, but myelopathy can have multiple etiologies, whereas myelitis is usually refers to an inflammatory or an infectious process. Another term that is commonly used when you describe cord signal change within the spinal cord is myelomalacia, which refers to permanent spinal cord damage with volume loss. So three terms are used: myelopathy, myelitis, and myelomalacia. Another terminology which is used often is acute transverse myelitis. So acute transverse myelitis is a clinical presentation of acute myelitis in which the spinal cord is affected in a bilateral fashion, resulting in sensory and motor changes on both sides of the body. The Transverse Myelitis Consortium Working Group proposed a CSF and MR criteria for diagnosis of idiopathic transverse myelitis, which includes spinal bilateral motor, sensory, and autonomic dysfunction, bilateral sensory level symptoms and signs, spinal inflammation on MRI or CSF tests, and symptoms with a duration ranging from a few hours and 21 days from onset to maximum deficits, and when extraaxial compression is ruled out. The key to understanding the approach to myelopathy, in my opinion, as for all of radiology, is to understand the knowledge of the spinal cord anatomy, which will be key to localize where the myelopathy is coming from. Myelopathies can be broadly attributed to compressive and non-compressive causes. Compressive myelopathy is a term where you use when the lesion is extrinsically compressing the spinal cord, and that can be extradural, intradural, extramedullary, or in the intramedullary space. When you see an intramedullary T2 hyperintense cord signal change in the setting of acute cord compression, it's an urgent finding and probably indicates acute cord edema and ischemia. And that is the time when you really need to pick up the phone and call the clinician that there is cord compression and cord ischemia. Compressive myelopathy is usually managed with neurosurgical decompression, and treatment of non-compressive myelopathy depends on the specific cause of the disease. So localization of compressive myelopathy is extremely important. And just going back to anatomy, the three meningeal layers, which are the dura, arachnoid, and pia mater, encase the spinal cord, nerve roots, and chorda equina. These layers form the four boundaries that we commonly describe in our reports. That's the epidural space, the subdural, subarachnoid space, and the intramedullary space. So this is an image from an axial image from an MRI. So the first space that we'll talk about is the epidural space. So this epidural space is a space defined between the bony spinal canal and the dura mater. The one in red is the dura mater. So anything outside of this is the epidural space, and this contains the epidural fat, the spinal nerves, the arterioles, the venous plexi, and lymphatics, which communicates directly with the paravertebral space. The next space that we talk about is the intradural space. Intradural space is the space between the arachnoid mater and the pia mater. This pia mater is depicted in black. So this is the intradural space, and which contains the CSF, the nerve fibers, the vascular elements, and glial tissue. There is also a potential subdural space which lies between the arachnoid mater and the dura mater, which is closely opposed secondary to thin bridges of collagen, and you normally don't see it on imaging unless there is a collection secondary to an LP or trauma that this space fills up. Central space is the intramedullary space. This is the space which is described within the substance of the spinal cord. So you have the epidural space, you have the intradural extramedullary space, and then you have the intramedullary space. Briefly about spinal cord anatomy, the spinal cord itself is contained within the thecal sac and begins at the foramen magnum cranially and ends at the tip of the conus medullaris between the L2, L3 disc base and typically ends around the L1, L2 disc. The lower segment of the spinal cord is termed as conus medullaris, which terminates between T12 and L1 and is anchored to the first coccygeal ligament through a connective phylum continuous with the pia mater called phylum terminal. Below the apex of the conus medullaris, it is served nerve roots, which is known as the cauda equina nerve roots. In terms of spinal cord anatomy, the spinal cord is divided into the right and left halves by a ventral median fissure or the anterior median fissure and a posterior median sulcus. The dorsal nerve roots enter the cord on the posterior cord surface through the dorsolateral sulci, and the ventral roots emerge from the anterior cord surface through the ventral sulci. In contrast to the gray matter in the brain, the gray matter in the spinal cord is located centrally surrounded by the white matter columns. So this is the central gray matter surrounded by the white matter. The gray matter appears as an edge-shaped or a butterfly-shaped region. The central gray matter has ventral and dorsal extensions, which are known as the horns, and a lateral horn at the T12L1 segments. So these are the ventral horns, and these are the lateral horns of the gray matter in the spinal cord. This is the normal appearance of the spinal cord. This is a zoomed up image from a GRE, a gradient echo sequence of the cervical cord, which shows this edge-shaped appearance of the central gray matter surrounded by the white matter. And this is the zoomed up image of the same. In terms of the white matter in the spinal cord, it consists of three main columns, as we remember from our days in medical school. That's the anterior, lateral, and posterior columns, and ascending sensory and descending motor pathways travel in these columns, and these are located anterior, posterior, and lateral to the spinal, to the gray matter itself. The white matter tracts, specifically the dorsal columns, lateral corticospinal tracts, and spinal thalamic tracts, are located around the periphery. 10% of the corticospinal fiber tracts do not decussate and continue ipsilaterally as the anterior corticospinal tract. So just in brief mention about spinal cord syndromes, which is of course outside the scope of this talk on radiology, but when we get a requisition, that's usually, the clinician has examined the patient and has, either given the symptoms, has come across, either patient has complete spinal cord involvement, that's involvement of all the tracts, Brown, Sequard, or hemispinal cord syndrome, where there is ipsilateral corticospinal tract, posterior column, and contralateral spinal thalamic tract involvement. Anterior spinal cord syndrome with anterior horn cells, corticospinal tract, spinothalamic, and autonomic tract involvement. Posterior spinal cord syndrome, where you have posterior spinal cord involvement. And central syndrome, where you have spinothalamic crossing, corticospinal tract, and autonomic tract involvement. And cauda equina involvement is when you have the cauda equina nerve roots involvement, which may be secondary to infection, polyradiculitis, or compression. In brief about the spinal cord blood supply, the spinal cord blood is supplied by the two main arteries, the anterior spinal artery, and the paired posterior spinal arteries. The anterior spinal arteries are formed by the fusion of the vertebral arteries, whereas the posterior spinal arteries arise from the posterior inferior cerebellar arteries or the vertebral arteries. The main artery to remember in the cord is the largest radicular artery, which arises from the left side of the aorta between T9 and L2 vertebral levels, is known as the artery of Adam-Kiewitz. This artery provides a common blood supply to the lumbar and sacral segments, and it commonly demonstrates a hairpin bend before joining the anterior spinal artery. So this is the anterior spinal artery, the posterior spinal artery, which supplies the central cord. On imaging, MRI is the standard imaging technique for evaluating myelopathies and their mimics. CT is useful to reveal bone abnormalities such as fractures or spondylolysis, or for post-surgical evaluation to assess instrumentation of posterior fusion potential complications such as hematomas and abscesses. CT is also useful and a first-line technique in trauma patients. It's also good for depiction of ligament disossification, canal stenosis, and cord compression. CT with intravenous contrast and CT myelography is useful for patients where MR is indicated or not available. And a conventional angiogram or a DSA is useful for vascular malformations and spinal cord infarcts. So the protocol we use here at MGH, the MR sequences commonly used to evaluate myelopathy includes a T1 weighted image, a T2 weighted image, a STIR image, a T2 GRE or T2 star image, a diffusion weighted image, especially when you're suspecting a cord infarct, and post-contrast images of the spine. The T1 weighted images are useful, especially when you're looking for any hemorrhagic components, fat, or melanin. T2 and STIR are the main sequences where we look for hyperintense signal, which we see in myelopathies. Literature has shown that proton density and STIR have a higher sensitivity to detect cord signal changes, especially in cases of multiple sclerosis. A T2 star or a gradient sequence is useful to evaluate for hemorrhagic components in trauma patients, tumors, and vascular malformations. And any bleeding in the cord has a poorer prognosis as opposed to just a T2 signal. A diffusion weighted sequence is useful to demonstrate restricted diffusion in cases of spinal cord ischemia and abscesses. And a post-contrast T1 can depict the patterns of enhancement. And an MR angiogram is usually reserved for patients who have suspected vascular malformations to demonstrate abnormal vasculature and to provide a roadmap for spinal arteriography. So our diagnostic approach on MRI is to localize of where the lesion is, where the abnormality is. Is it intramedullary? Is it extramedullary, intradural, or is it extramedullary or intradural? And this sort of flow chart I find is extremely useful in cases of myelopathy. And this is from the literature from radiological clinics of North America, which I have sort of used for this presentation and changed it a little bit. But this is how if you see a cord signal change within the spinal cord, the first thing that we do is you exclude whether this is an artifact or a real lesion. If the presentation is acute, then you follow this laundry list of causes. And if the presentation is subacute or chronic, you follow this laundry list of cases. So the first thing that you need to rule out if you have excluded artifact is rule out cord compression. If cord compression has been ruled out, then the other causes include ischemia, demyelination, inflammatory conditions, infectious, and idiopathic causes. In a subacute or chronic presentation, again, exclude artifact, rule out compression, and then the non-neoplastic causes includes metabolic, spinal dural AV fistulas, cavernomas, radiation, paraneoplastic or autoimmune diseases, and the big category is neoplastic causes of spinal tumors. So artifacts is a big thing when you have a lot of scans going on. So look and evaluate for artifacts at spine imaging. The commonly seen artifacts at the spinal cord includes the grips or the truncation artifacts, which are seen at high contrast interfaces, respiratory motion, vascular pulsations, and CSF pulsation. And then these appear as alternating lines of low and high signal along the long axis of the spinal cord. The solution to get rid of this is to increase the number of phase encoding steps or switch the frequency of phase encoding directions or decrease the seal of view. So this was the case, and this is how they appear as Gibbs artifact, where you have alternating lines of high and low signal in the central cord. So once you have excluded artifact as the cause of a T2 hyperintense signal change within the cord, the next thing that you have to rule out is compression. So the common causes of compression include degenerative spondylolysis, trauma epidural pathologies such as metastases and intradural tumors. On MR, a compressed spinal cord could have normal signal, an elevated signal, or may have T1 hyperintensity with accompanying T2 hyperintensity, which has, in severe cases, has worse prognosis because at that time point, the patient already has cord myelomalacia. So amongst the compressive causes, degenerative is the main bucket of diseases which can cause extrinsic cord compression. This is a MRI of the cervical spine showing a disc extrusion with superior and inferior migration, causing indentation on the thecal sac and spinal cord. This is lower down at the L4, L5 level, where there is an extruded disc which is compressing the cord equina nerve roots. The next bucket of cord compression, extrinsic cord compression, is trauma. This was a trauma patient where you have a corner fracture with retrolisthesis on CT. On MR, there is a prevertebral hematoma, disruption of the anterior and posterior longitudinal ligaments. There is a T2 hyperintense cord signal change, as well as posteriorly. You can see that there is ligamentous injury in terms of supraspinous and interspinous ligamentous cord disruption. And there's an extruded disc here, which is causing compression on the cord with cord edema. Infection is the other big categories, and the big bucket here is to rule out osteomyelitis, discitis. Here you have a case where you have a peripherally enhancing fluid collection in the intervertebral disc with an anterior and posterior epidural component, which is compressing the cord anteriorly as well as posteriorly and causing cord signal change. Epidural abscess is another cause which can cause cord compression. Here you can see a peripherally enhancing collection in the posterior epidural space, which is causing compression on the cord with cord signal change. In post-op patients, you can have post-operative seromas where the patient would present with a collection in the posterior epidural space of the paraspinal soft tissues, which is compressing the thecal sac posteriorly and causing cord compression. Metastasis is another important cause. This is a patient here. You have almost like a vertebra planar configuration of the T6 vertebral body with pathological fracture, with abnormal soft tissue in the epidural space, which is causing compression on the cord, as well as abnormal pre- and paravertebral soft tissue. Tumors, nerve sheath tumors, or any tumors extrinsically can compress. This was a nerve sheath tumor which is compressing and displacing the cauda equina nerve roots laterally. This was a nerve sheath tumor which is a dumbbell-shaped tumor which is growing out the neural foramen, but it is causing and displacing the spinal cord on the right side, towards the right side. So once on myelopathy, and I'll come back to the slide again and again, you've excluded a T2 hyperintensity, you have ruled out cord compression, and now if the patient has presented acutely, we can go down this list of differential diagnoses. So the first, in an acute setting, you worry about spinal cord ischemia. Spinal cord ischemia is abrupt occlusion of one of the arteries that supply the spinal cord. It has a hyperacute prognosis, progression, rapid onset, and profound deficits. Ischemia most commonly affects the territories of the anterior spinal arteries, and the lower thoracic spinal cord is where it is most commonly involved. The most commonly identified etiology is usually atherosclerosis, but most oftentimes you do not find a cause of why there is spinal cord ischemia. On MR, there'll be T2 hyperintensity within the central gray matter, producing an H-shaped region of abnormality. This was a young patient who had come to our emergency room with lower extremity weakness and paralysis. This is a diffusion-weighted sequence which shows abnormal signal within the cord with restricted diffusion. On the T2 weighted sequences, you can see a cord signal change within the cord. This patient underwent a spinal angiogram, but no identifiable cause of involvement was found, and it was presumed to be due to a fibrocartilaginous embolization. This was another case where there was cord signal change within the spinal cord, and this was presumed to be spinal cord ischemia secondary to a mural thrombus in the descending thoracic aorta. The other big bucket of diseases in an acute presentation is demyelinating diseases. Multiple sclerosis is a demyelinating disease that affects the brain and spinal cord and is characterized by lesions that are disseminated in both space and time. Lesions that are most commonly involved are in the cervical cord. Patients with primary progressive MS tend to have more spinal cord lesions than patients with relapsing remitting MS. Although transverse myelitis is a possible clinical presentation, partial myelitis is much more common. Typically, MS lesions are short segment lesions. That means that they are involve less than 2 vertebral segments. These occur at greatest frequency along the dorsal and lateral portions of the spinal cord. On MR imaging, MS lesions are T2 hyperintense, and over time, they can still be visible on T2-weighted images. Acute lesions can be expansile. On post-contrast images, you can have a peripheral limb of enhancement or an open or C-shaped limb of enhancement, which is highly suggestive of a demyelinating process. Enhancement usually does not persist beyond 3 months, and this is a useful discriminating feature to differentiate multiple sclerosis from other diseases. So this is a case that we had at our hospital. As you can see in the cervical spine, there are T2 hyperintense cord signal changes within the cervical spine, and this is along the posterolateral margin on the right. This is along the posterior lateral margin on the left side. And you can see that these are short segment lesions. They are not contiguous lesions. So short segment lesions along the posterior and lateral margins, think of multiple sclerosis. This is an example of an acute MS plaque where there was cord signal change within the cord with enhancement when expansion of the cord. Within the spectrum for demyelinating disorders, the second group of diseases that we come across is neuromyelitis optica, which is characterized as spinal cord involvement, most commonly in the setting of acute transverse myelitis and optic neuritis. Clinically, deficits in NMO are typically more severe than we see in MS, and recurrent attacks are common. Most patients with NMO have elevated levels of aquaporin 4, which is a water transport channel found in the epidermal cells. This antibody aquaporin 4 is highly specific for NMO. More recently, a new terminology has been used, that's the NMO spectrum disorders, which has been used to encompass patients who clinically present with neuromyelitis optica, but who are aquaporin 4 negative. And these patients present immunoreactivity to another antibody known as myelin oligodendrocytic glycoprotein, or MOG. As opposed to MS, on imaging, NMO categorically demonstrates a longitudinally extensive transverse myelitis, T2 hyperintense, expansile lesion. Central portions of the spinal cord are involved, and sometimes you can have T2 hyperintense signal within the cord itself, known as brighty spotty lesions. The brain initially was thought to be clean in patients with NMO, but is now recognized that brain lesions are not uncommon, and they tend to predominate in regions around the third and fourth ventricles. The distribution is in contrast to ovoid Dawson fingers that has been classically described in patients with MS. So this was a patient who presented, who's diagnosed with neuromyelitis optica, where you can see an extensive cord signal change within the cord itself, with some patchy enhancement on the post-contrast images. On brain imaging and orbital imaging, there is enhancement of the optic nerves bilaterally. The brain itself was normal. This was a patient with myelin oligodendrocytic MOG positivity, and you can see T2 hyperintense cord signal change within the thoracic cord, enhancement on the post-contrast sequences, and the brain was really unrevealing except a small lesion here, which is non-specific. In kids, an entity which has been described as acute disseminated encephalomyelitis. which is a disease that affects the brain and spinal cords. Most cases occur in childhood, and there's usually a preceding respiratory or GI illness. Classically, it's a monophasic illness. And again, on spinal cord imaging, you have a longitudinally extensive transverse myelitis, expansion and variable enhancement. Brain imaging is usually useful in patients where you're suspecting acute disseminated encephalomyelitis. As you will see, T2 hyperintense lesions throughout the white matter, as well as involvement of the deep brain nuclei. So this was a 10-year-old boy who presented with lesions in the brain where you can see extensive confluent involvement in the periventricular deep and subcortical white matter, as well as deep gray nuclei involvement. On MR, this is an older case, but there is longitudinally extensive T2 cord signal change within the cord. And this was a case of ADEM. The next category are the systemic inflammatory conditions, including SLE, Sjogren's syndrome, mixed connective tissue disorders, and sarcoidosis. Again, on MR, they present with longitudinally extensive transverse myelitis, that is cord signal change within the cord, and it's really hard to differentiate these lesions unless you have a good clinical history and further workup, because despite the similar imaging appearance, the pathophysiology of these conditions are different. For example, in cases of SLE myelitis, they've been found to be associated with antiphospholipid antibodies, suggesting that an SLE myelitis is a thrombotic rather than an inflammatory condition. Behçet's disease is a condition which is accompanied by oral and genital and aphthous ulcers, is a systemic vasculitis, and there may be some crossover with neuromyelitis optica. This was a patient who had systemic SLE, and again, you can see cord signal change within the thoracic cord. And if I didn't give you the history, they look exactly the same as the previous cases I had shown you. Sarcoidosis is a granulomatous condition where you can have centripetal patterns of enhancement, and spinal cord involvement can mimic actually anything. They can have leptomeningeal, pachymeningeal, intramedullary, and rarely vertebral body involvement. You can have involvement of the choroid minor, of the optic nerves. What is useful in these cases is to get a chest CT, and roughly half of patients of neurosarcoidosis will have hilar retinopathy. Serum and CSF angiotensin converting enzyme levels also have high specificity for sarcoidosis. This was a case we had for biopsy-proven sarcoidosis, where you have longitudinally extensive cord signal change within the cord itself. And on a chest CT, you see multiple hilar lymph nodes. The thoracic spine also showing these cord signal changes within the thoracic cord with some patchy areas of enhancement. This was another case that we had of sarcoidosis, and the reason for showing you this case is that this had vertebral body involvement, has osseous involvement of sarcoidosis. So sarcoidosis can actually mimic anything and can present as anything. This is a case that I pulled up from literature that we did not have this classic and such a dramatic appearance. What one sign that has been described as a trident sign, where there is crescentric layering with posterior subpial enhancement accompanied by central enhancement, leading to a three-pronged appearance resembling a trident head. Amongst the acute causes of acute myelopathy is infection. Infection of the spinal cord and nerve roots can be caused by bacteria, viruses, parasites, and fungi. The most common viral causes includes the EBD68, the enteroviruses, and the herpes viruses. MR classically shows a T2 hyperintensity of the anterior horn cells. Bacterial infections associated with bacterial meningitis or adjacent vertebral or disc space infection can cause myelopathy, fungal infections, including Aspergilla and Candida, can cause these abnormalities. Parasitic infections, depending on which part of the globe you're in, cysticercosis, schistosomiosis are not uncommon. This was a case of varicella zoster myelitis. There's T2 hyperintensity within the middle cerebral peduncle with involvement of the trigeminal nerve, and enhancement on the post-contrast sequences in the brain. And in the spinal cord, there was patchy areas of cord signal change within the cervical and dorsal spine. For the sake of completeness, another entity, an infection is HIV myelopathy, where you have T2 hyperintensity within the posterior columns, which may mimic a subacute combined degeneration of the cord. So idiopathic acute transverse myelitis, by definition, lacks an identifiable cause after comprehensive evaluation. So once you have ruled out demyelinating vascular infections or other connective tissue disorders, is usually an uncommon diagnosis. And previous studies have shown that patients who were initially suspected at idiopathic ATM, only 16 to 18% retained a diagnosis after full workup as to the cause of transverse myelitis. So again, coming back to this chart again, you see a T2 hyperintensity within the cord. You exclude myelopathy. You exclude an artifact. You exclude cord compression. And then in the acute presentation, we looked at ischemia, demyelination, inflammatory conditions, infectious and idiopathic etiologies. And then if the presentation is subacute or chronic, you've again ruled out compression. And then now we're going to look at the list of non-neoplastic and neoplastic causes of subacute or chronic myelopathy. So among the non-neoplastic causes of subacute or chronic myelopathy, metabolic is the most common, and the best known is B12 deficiency. So B12 deficiency causes patchy areas of demyelination within the spinal cord, with a particular predilection for the dorsal column. On MR, you will see increased T2 signal within the dorsal columns of the cervical and upper thoracic spine, described as chevron-shaped appearance on the axial images, referred to as an inverted V or inverted rabbit ear sign. Other causes includes exposure to nitrous oxide, copper deficiency secondary to gastric surgery, malabsorption, and prolonged parenteral nutrition, excessive ingestion of zinc or tabes dorsalis in patients who have syphilis. This was a young patient who had a nitrous oxide overdose. And this, you can see this young patient had T2 hyperintensity within the central cord with an inverted V-shaped or a chevron-shaped appearance resembling rabbit's ears, which I pulled from literature. This was a 53-year-old woman who presented after a gastric bypass, and you can see that there is cord signal change within the posterior part of the spinal cord involving the dorsal columns. Among the non-neoplastic causes, the other cause is vascular causes. So vascular causes of the spinal cord are rare but potentially devastating conditions, and accurate recognition is critical to determine its clinical outcome. And several conditions lead to myelopathy: arterial ischemia, venous congestion, and bleeding within the cord. Spinal dural AV fistulas is a common entity within the vascular lesions. There, of course, a lot of types of vascular pathologies, but for the sake of this talk, we'll just focus on two ones, which are the dural AV fistulas, which is a communication between the arteries and veins. An increased venous pressure causes vascular congestion in the spinal cord parenchyma, producing cord edema and decreased arterial perfusion. The typical presentation is an older male with a history of non-specific myelopathic symptoms. Clinical picture is sometimes referred to as Fox-Allogene syndrome, and patients' symptoms are related to lower extremity edema and ischemia. T2 weighted images show serpiginous flow voids and the presence of sometimes a T2 hyperintense rim, but you may or may not see it, and you will have variable contrast enhancement. MRA is usually reserved to evaluate for the level of the fistula in case surgery or intervention is planned. These are schematic diagrams of a type 1 intradural AVF, where you see the connection between the artery and vein adjacent to the nerve. This was a case of a 79-year-old male with lower extremity weakness. You can see T2 hyperintensic cord signal change within the cord itself, and these squiggly serpentinous flow voids suggesting that there is a vascular etiology to this cord signal change. The second big category under vascular is a type 2 AVM, which is a spinal glomus AV malformation. These are congenital high flow lesions, and 50 to 75% of patients may present with acute or subacute symptoms, and you will see a nidus deep to hyperintensity within the cord with cord expansion. This is a schematic diagram showing glomus AVM within the spinal cord itself. This is a CT image of the cervical spine showing an enhancing lesion within the spinal cord with dilated veins and a nidus. This is an MR of a 45-year-old male present with lower extremity weakness and conus, and you can see multiple flow voids and veins and vessels traversing in the upper cervical spine with a nidus with abnormal post-contrast enhancement. Completing the list of vascular causes, is a spinal cavernoma. These lesions are relatively rare in the spinal cord, but when they present, can lead to severe neurological deterioration and significant hemorrhage and mass effect. On MR, you will have a multicystic appearing lesion with a popcorn appearance. A low T2 signal representing hemosiderin deposition. No flow voids are seen because cavernomas lack arterial feeding vessels, as opposed to the brain, where cerebral cavernous malformations tend to remain asymptomatic. Spinal cord cavernomas, present because of less space availability, and they hemorrhage more frequently, producing mass effect and myelopathic symptoms. This was the appearance of a spinal cavernoma in the spinal cord. You can see a popcorn-like lesion within the spinal cord itself with some contrast enhancement. Radiation can also cause subacute or chronic myelopathy. The risk of myelopathy is dose dependent. The average presentation is between 6 months to 2 years. Again, on MR, you will see T2 hyperintense lesions within the central spinal cord. The key to recognizing radiation-induced myelopathy is changes in the adjacent vertebral bodies, which will appear as T1 hyperintense marrow and will correlate with a prior radiation port. This was a case where the patient had a posterior fossa tumor for which he had received radiation in childhood, and the patient presented with cord signal change at the craniocervical junction. And you can see that the marrow has been replaced, and this is fatty marrow replacement secondary to radiation. To complete the list of causes, you can have paraneoplastic and autoimmune myelitis, and we see a lot of autoimmune myelitis, at least here in the US. And these are associated with a lot of tumors, especially lung, breast, thymoma, and ovarian tumors. Another potential trigger is viral infections, especially herpes, can trigger a reaction to NDMA receptors. On MR, you can see a T2 signal abnormality involving either the lateral, dorsal, or central gray matter. Amongst the neoplastic causes of subacute to chronic myelopathy, it's relatively a rare cause of myelopathy and is less common than acute demyelinating and inflammatory causes. And as a general rule, spinal cord tumors will show cord expansion and enhance in post-contrast images. Demyelinating causes which show expansion, like we had seen in the case of MS, which usually stop enhancing in 6 to 8 weeks, whereas spinal cord tumors will show persistent enhancement. And the reason it's important is it's sometimes good to get a follow-up of these patients because spinal cord biopsy has its own morbidity associated with the biopsy itself. And most spinal cord tumors usually exhibit slow clinical progression, and repeat imaging is a useful strategy. The most common one in adults is an ependymoma. Most ependymomas are WHO grade 2 classic ependymomas, and myxopapillary ependymomas are a subtype which arises from the Cohen's medullaris. They're typically central, well circumscribed, and because of their location within the central cord, they're usually associated with the syrinx or a polar cyst or a non-tumoral cyst located above or below the tumor nodule. Hemorrhage at the margins of the tumor has been described classically in cases of ependymoma which present with a hemosiderin gap. This was a patient of ependymoma where you can see that there is expansion of the spinal cord. There's central T2 hyperintensity, and you can see this dark signal on T2, which you can see on the GRE sequence is actually a hemosiderin gap with patchy contrast enhancement. The second most common tumor and the most common in pediatric populations is an astrocytoma. These are usually WHO grade 1 or 2. As opposed to an ependymomas, astrocytomas are infiltrative with poorly defined margins and may involve the entire spinal cord, known as holocord astrocytomas. Fusiform expansion is the rule with corresponding T2 hyperintensity. And hemorrhage is not a common feature of astrocytomas. And the reason it's sometimes useful to differentiate ependymomas and astrocytomas is that the surgeon can remove an ependymoma in toto as opposed to astrocytomas. Here you can see that the ependymoma has a well-defined margin that the surgeon can remove, as opposed to an astrocytoma, which is more infiltrated. Like in this case, where you can see that there is cord expansion and cord signal change within the cord, and then there is this infiltrative enhancement. So it would be hard for the surgeon to identify the margins of such lesions. The third big category is in hemangioblastomas. This is the third more frequent category of spinal cord tumors. These are characterized by circumscribed and intensely enhancing nodules, usually located extrinsically. These are highly vascular lesions and may be associated with dilated vessels producing flow voids. Classically, cyst with a mural nodule appearance has been described. And when you have multiple hemangioblastomas, think of von Hippel-Lindau. This was a case of von Hippel-Lindau, where you have multiple cerebellar hemangioblastomas, cord signal change within the cervical cord with the cyst with an enhancing mural nodule and multiple enhancing lesions along the surface of the cord. So this was a case of hemangioblastoma associated with von Hippel-Lindau. Metastases is extremely rare, but most commonly, if seen, is seen in the cervical cord. The most common tumors associated are lung, breast, melanoma, and renal carcinomas. They show intense enhancement and large edema, as you see in the brain. This was a case which was prospectively picked up at our division. This patient presented with extensive longitudinal cord signal change. And one of my colleagues had astutely picked this up on the localizer sequence of the cervical and thoracic MRI, that there was a lesion in the lung. This was not biopsy proven, but it is presumed to be mets from the lung cancer, which we had picked up on the scout images. Syringohydromyelia is not an infrequent intramedullary lesion, and these terms, hydromyelia and syringohydromyelia, are used interchangeably. Syringomyelia refers to accumulation of CSF in the paracentral cavity in the white matter adjacent to the central canal, but it's on radiologically, it's hard to differentiate between the two terms, and we just, for all practical purposes, use the word syrinx. The major etiologies include KRE1 malformations, traumas, and tumors. And it's reasonable to recommend a follow-up imaging if you see a syrinx on imaging to ensure stability. And contrast is usually recommended to rule out an underlying tumor. So this was a case of syringohydromyelia. This had a KRE malformation. You can see CSF-I-27 cord signaling change. So this is already cord myelomalacia within the cord itself. Last, just to complete, for the sake of completeness, is neurodegenerative diseases. Motor neuron diseases of the spinal cord represent a rare and fatal group of disorders, which includes lateral sclerosis, spinocerebellar ataxias, and ALS. It's the most common type of motor neuron disease where there's atrophy of the anterior horn cells, resulting in muscle weakness, cramps, fasciculations, and eventually a progression to respiratory failure. The diagnosis of ALS is made rarely made by imaging alone, but on MR you will see T2 hyperintensity involving the anterolateral columns without associated spinal cord atrophy. The degree of spinal cord atrophy, especially gray matter, correlates with the degree of disability at both baseline and follow-up examinations. This is a case from literature that I have taken where you can see T2 hyperintensity along the lateral columns and along the corticospinal tracts. With that, just to summarize on the clues to when you're approaching a case of myelopathy is look at the onset of symptoms, whether it's acute, subacute, or chronic, the type of symptoms, pain, weakness, sensory, or autonomic. Do relative laboratory analysis, blood and CSF. Clinically, see if there's upper cervical cord involvement, quadriplegia, but impaired sensation. A lower cervical cord lesion may lead to hand and leg weakness. Thoracic cord involvement leads to paraplegia. Posterior column, think involvement if there's loss of vibration and proprioception. And spinothalamic if there's loss of pain and temperature. So the pearls to remember is localize the site of myelopathy, location in the cord, look for associated brain involvement, cord expansion, or atrophy, the patterns of enhancement, presence of calcification or hemorrhage, or any vascular abnormalities in secondary syrinx formation. In acute myelopathy, short segment lesions, think of multiple sclerosis. Longitudinally extensive, think of neuromyelitis optica. If you have hyperacute onset, think of arterial ischemia, and get brain imaging to narrow the differential diagnosis. Chest imaging to look for hilar lymphadenopathy in cases of sarcoidosis, and CSF analysis to look for markers of inflammation and specific antibodies such as aquaporin 4 is helpful in acute myelopathies. In subacute or chronic myelopathies, if there's involvement of the dorsal columns, think of B12 deficiencies. Examining the dorsal surface of the cord to rule out a dural AV fistula. And if you have an expansile lesion and you cannot differentiate between a tumor and an inflammatory lesion, get repeat image 2 to 3 months. With that, these are the references that I have used, and I think these are useful references. If somebody wants, I'm happy to email them to you. And thank you so much.
Thank you very much, Dr. Saurabh. It was very comprehensive lecture, and I enjoyed the cases you have shown. They were beautiful. And on behalf of Gapio, I thank you for your time, and I hand over to Dr. Vinita.
Yeah.
Thank you.
Yeah, thank you, Dr. Gandhi, and thank you, Dr. Saurabh. This was really very informative, and I'm practicing MR spine and also MSK spine, so it was really very helpful to understand this. I think we are running a bit over time now. There are, I think, a few questions. May I ask, request Professor Gandhi to join? Maybe we can take 1 or 2 questions before we end the session. We have.
So we had a question. which you partially answered from UAE. What is major difference between MS and imaging myopathies?
So I think MS is usually when you have MS lesions, they're usually short segment lesions as opposed to other causes of myelopathy where there are usually long segment lesions. And when you're suspecting specifically multiple sclerosis, usually it's a younger population. On brain imaging, there are classical features of Dawson fingers where you have periventricular involvement along the longitudinal axis of the corpus callosum. So those are the other ancillary features that you have to look for. Optic nerve involvement, long segment spinal cord involvement, think of neuromyelitis optica. If there is no brain involvement, think of MOG or NMO or things like that. But the clinical and lab parameters would also have to be taken into consideration before you make the diagnosis.
Thank you.
Okay, thank you so much. Maybe I'll invite Dr. Sushil Jain, our honorary or secretary, so to end the session today.
Thank you, Dr. Vinita. I'll take this opportunity to thank Dr. Rohtagi and Professor Gandhi, Dr. Vinita, and everyone else who has, Dr. Anju Agrawal, she has joined from Australia, and everyone else who has made this possible, and also my colleague, Mr. Jitendra Malik from Delhi. Because of them, it has been possible. Also, thanks to the IT team, which has taken all the pains to make this session possible. Thank you. Thank you, everyone.
Thank you very much.
Thank you, everyone.
Thank you.
That was excellent talk, Dr. Rohtagi. Thank you.
Thank you. Thank you for having me. Yeah.
Maybe we can have some follow-up conversation later.
Sure. I think somebody has a hand up. I'm not sure if we can.
Just a quick one. Has the COVID changed the scene?
So COVID has changed the scene a little bit, that we do see post-COVID changes of cord signal change within the cord. But it's very hard to prospectively say that this is because of COVID, but we do see cases of COVID inflammatory changes in the spinal cord.
Thank you very much.
Yeah.
Nice to hear from another Nagpurian.
Thank you.
Thank you.